Hello, sir. Good evening. So thank you so much for hosting this lecture. Our students and my faculty, friends also will benefit from this a lot.
Yeah, good evening, Dr. Chitness, and we'll wait for some more time,
Absolutely fine, sir. Yes.
right? Because there is still 4 minutes left.
Yes, sir. Sure. Yes, sir.
Hmm? So, good evening, everybody. Those who are present, are you able to hear?
Yes, sir.
Okay. Dr. Chitness, shall we continue?
Yes, sir. Absolutely. Go ahead, sir. Thank you so much.
So, today we will be discussing about clinical stroke syndromes and relevant cerebrovascular anatomical correlation So in the process, we will be discussing what is stroke and stroke syndromes. And we can go to the definition, old definition, acute neurological deficit of vascular origin. More than 24 hours, that deficit should last. That was the earlier definition. The important point to note is the vascular origin. It should be related to the blood supply of a particular area of the brain which is deprived of oxygen and glucose. Now, moving to a new definition, because strokes can be silent or asymptomatic. They may be short-lived episodes, less than 24 hours, but with cerebral injury. That is, earlier it was considered as transient ischemic episode, but now we know that they are mild strokes. So the new definition is now image-based. Cerebral infarction in brain or retina death due to prolonged ischemia, retinal cell death. And the most important differential diagnosis is intracerebral hemorrhage. So whenever a person comes with features suggestive of stroke, that means sudden onset of hemiparesis, loss of speech, facial deviation, arm weakness, right? And that time, the differential diagnosis between ischemic stroke and intracerebral hemorrhage. Ischemic stroke is about 83%, and there are various types of ischemic strokes. Some are involving the large artery strokes, which are about 20%. Some come from either heart or a proximal large vessel to the distal vessel. These are called artery to artery embolism, 20%. And lacunar strokes are small vessels. When you look at the blood supply, the large vessels branch into small, medium-sized, and medium-sized vessels branch into small vessels. And each blood vessel, small vessel, supplies a particular area. If that blood vessel gets blocked, then lacunar strokes come in 25%. Still, about 30%, we will not know what is the exact pathophysiology. In contrast, the hemorrhagic stroke is seen in 17%. And mostly it is inside the brain when it's called intracerebral hemorrhage, 59%. And all around the brain, then it's called subarachnoid hemorrhage, 41% of the hemorrhages. So 17% total hemorrhagic stroke. In that, almost equal distribution, but more often it is intracerebral hemorrhage, then less often it is subarachnoid hemorrhage. So to look at the blood vessels, you can see the heart, the aorta, you can see the atria of the heart, and these are the heart valves. You can see the right atrium, left atrium, the arch of aorta, which is coming from the left ventricle. And there may be valvular disease, which can give rise to stroke. There may be atrial fibrillation, means atria, they contract more than 300 to 400 times per minute. That's called atrial fibrillation. All these contractions may not go down to the ventricle because there is an AV node here which blocks some of them. But at times they may get into ventricular tachyarrhythmias. And because of this fast atrial fibrillation, there is blood clots here and they can get embolized to the arteries, the going into the cerebrum. So that's one that is called cardiogenic emboli, which you can see they're going, they can reach anywhere in either brain or the limbs also. Apart from that, if there is derangement of lipids in the brain and in the body, then they can get accumulated in the blood vessels, causing atherosclerotic plaques. And these plaques you can see here, and they gather some amount of thrombus among them because a rough area. And this thrombus, which gets slowly accumulated, is very fragile. It can get dislodged and go distally into the small blood vessels, or it can reduce the blood flow, decreasing the oxygen and the glucose requirements of the brain. So these are the essential things which you should know about the pathophysiology. And you can see blood supply to the brain is divided basically into anterior circulation and posterior circulation. The anterior circulation is provided by internal carotid. The common carotid artery divides into external carotid and internal carotid artery. And all the posterior circulation, both the vertebral arteries join to form the basilar artery, and which goes and supplies to the posterior part of the brain. So we'll see anterior circulation mostly supplies cerebral hemispheres, and large part of the brain is supplied by middle cerebral artery. You can see these are the branches of the basilar artery, which is on the base of the brain. And there are branches of carotid artery or middle cerebral artery, and you can see the internal carotid artery here, and anterior cerebral artery. So middle cerebral artery, anterior cerebral artery, and the posterior cerebral artery you can see here, and these are connected by posterior communicating artery. So this whole circle is called circle of Willis, the circle of Willis. And the basilar artery gives rise to superior cerebellar artery and posterior inferior cerebellar artery and anterior inferior cerebellar artery. So these are the branches which supply cerebellum, brainstem, that is medulla and pons. So you can see these arteries are tapering and they end. These are all end arteries. If any clot happens here, this particular area gets necrosed. That is called lacunar infarct, a small vessel vascular disease. So all these big vessels have small branches, which you will see, and you can see more clearly the brachiocephalic artery and the subclavian artery, which will go. The vertebral artery is arising from here and is going into the brain, and you see it travels along the transverse foramen of the vertebrae and then enters into the brain. And this is under the common carotid artery, which you can see external carotid branching out and supplies face and jaw and other areas, and superior temporal artery also. The internal carotid artery, whereas travels craniad, and it goes through a carotid canal of the temporal bone and then cavernous sinus and then enters the brain. So this is a very tortuous long course, and you can have obstructions, atherosclerotic plaques anywhere in the course of these arteries. And once these big arteries enter the brain, they further subdivide into middle size and small size arteries. So that's the cerebrovascular anatomy. And you can see the small branches which are coming from the anterior cerebral artery. You can see the branches. That is, the first branch is a medial orbitofrontal branch, and the frontopolar branch, marginal branch, and medial pre-Rolandic branch. And you see this is supplying the secondary motor area. This is a callosal marginal, this is a pericallosal branch. And see this motor cortex and the sensory cortex, and these are all supplied by the middle cerebral artery. And you can, as you go under the back, the pericallosal artery goes to posterior parietal and subsequently splenic artery. So these are the middle cerebral artery and anterior cerebral artery territories which you are seeing. And here the posterior cerebral artery stem you can see gives rise to anterior temporal artery, hippocampal, medial posterior choroidal artery, posterior temporal artery, and calcarean branches which will say occipital lobe. These are parieto-occipital branches. So idea of telling all this is that these areas get their supply and all of them are end arteries. If there is a distal embolization, the embolus can come and lodge anywhere here, causing small areas of damage. If it happens very slowly, you can get small white matter hyperintensities all over the brain, which we call ischemic demyelination. And that will disrupt lot of networks in the brain, and which I'm going to show you the networks in some time. And because the networks, if they are disturbed, then the information won't get processed. So for the memory's sake, the internal carotid is the anterior circulation. You have ophthalmic branch, which is the first anterior cerebral branch, middle cerebral artery, posterior communicating artery, and anterior choroidal artery. So these are the main branches of internal carotid artery. Whereas vertebral artery gives rise to meningeal branches, and it gives a branch down to the spinal cord. This is anterior spinal artery and posterior spinal artery, posterior inferior cerebellar artery, and medullary artery branches. Out of this, pica is very important because we keep getting lateral medullary syndrome or Wallenberg syndrome. And the basilar artery has got anterior inferior cerebellar artery, which pica is from vertebral artery, aca is from basilar artery. It also gives us labyrinthine, pontine branches, which I showed you, superior cerebellar artery and posterior cerebral artery, which will supply the thalamus and the calcarine cortex and others, and it's a part of the circle of Willis. So you can see the leg area, the foot area, the trunk, the arm, hand, face, tongue. So you can see the territories. Where is the anterior cerebral artery territory is this much, and the middle cerebral artery territory is this much, and the posterior cerebral artery territory is this much. So if you look at the lateral aspect, these are the vascular territories, and you can see the Penfield map, and I can easily guess which part of the body is affected. Usually, when the cortex is involved, you can see the hand is very large area of representation. So you have differential weakness. Differential hand weakness more than the leg weakness. That is middle cerebral artery territory. Then that is called cortical stroke. So if an individual has more weakness in the upper limb than in the lower limb, along with the face, that's called differential weakness. It's called cortical stroke. The cortex supplies fibers which are carried like pyramidal tracts, and they go through the internal capsule, the anterior limb and posterior limb. When those areas are affected, you get a dense hemiplegia, which is equal in upper and lower limbs. If the lower limb weakness is more than the upper limb weakness, you can guess that is anterior cerebral artery territory, and you can know that, yeah, that is the area that could have been damaged. So the Penfield map usually helps us in identifying. You can see the post-central gyrus is the sensory and pre-central gyrus is the motor. And you can see the face area. The left cerebral hemisphere is the language area. So you can, if any individual has right hemiparesis, differential weakness, you should know that there could be aphasia. That's very important. So right upper and lower limb weakness, you always carefully look for speech defects. That's very important. And now, after having dealt with the anatomy part of it, let's go through some key physiological aspects. Cerebral neurons are fully dependent on cerebral blood flow. So there should be a constant supply of oxygen and glucose through the blood. The perfusion pressure should be optimal to keep a constant supply of glucose and oxygen, because if the blood flow stops, oxygen and glucose stops. You see that metabolic requirements are so much, so even if you stop for some time, there will be damage. So the key physiology aspects are very important for us to understand the stroke. So let us look at some of these aspects. If you look at the cerebral blood flow, it is about memory's sake, easy to remember, 50 ml per 100 grams per minute. If it is less than 18 to 20 ml because of a blood clot per 100 grams per minute, then physiological electrical function of cells begins to fall. So the normal perfusion pressure, which keeps the blood flow smoothly and the supply is constantly maintained, is about 80 millimeters of mercury. If it falls less than 50, then ischemia and reduced electrical activity sets in. So why we always look at the monitor and see what is the mean arterial pressure. That minus intracranial pressure, you get a cerebral perfusion pressure. See, blood pressure, you all know 120/80. If diastolic blood pressure is 80, 120 minus 80 is called pulse pressure. 1/3 of pulse pressure plus diastolic blood pressure is called mean arterial pressure. So that mean arterial pressure is maintained. And normally the intracranial pressure is about 12 to 15 millimeters of mercury. So if you have that much, you can easily guess what will be the normal mean arterial pressure. It will be around 80 plus 1/3 of 40. That means about 90 to 95. and 95 minus 15 is about 80. So if you have cerebral perfusion pressure, which is 80, then everything goes smoothly. But if it falls below that, then cerebral blood flow, which happens to be 50 ml per 100 grams per minute, also falls. Look at the requirements of oxygen consumption and glucose utilization by the neuronal cells. The oxygen consumption is 3.5 ml per 100 grams per minute. Suppose if that particular area which I showed you, end arteries, if it gets blocked, that area will survive only for 10 seconds if it is not restored. Then that particular area is damaged. Similarly, glucose is about 5 milligrams per 100 grams per minute is a requirement. So if a blood clot disrupts the blood supply, the storage capacity is only for 2 minutes. So oxygen 10 seconds, glucose 2 minutes, and beyond that the area gets damaged. So small infarcts keep on happening and they keep on disrupting the neural networks. So this is the basis of anatomy and physiology of the stroke, which everybody should know. That's because if there is a large vessel supratentorial acute ischemic stroke, per stroke, about 1.2 billion neurons are lost. And so many trillion, 8 trillion synapses are lost. 7,140 kilometers, the myelinated fibers are lost. And the individual ages by 36 years. A 30-year-old individual becomes 66 years almost. We look at that. Per second, 32,000 neurons are lost. 230 million synapses, 200 meters, and they age by 8.7 per second. This is, and per hour they age by 3.6 years. So time is brain. Every minute, if stroke is untreated, the average patient loses 1.9 million neurons, 13.8 billion synapses, and 12 kilometers of axonal fibers. That means approximately 7 miles. So each hour in which treatment fails to occur, the brain loses as many neurons as it does in almost 3.6 years of normal aging. So why we should know is because nowadays all these acute stroke treatments are time locked. You all know that we should identify stroke and treat them with intravenous thrombolytic therapy if they present to you within 4.5 hours of the onset, or endovascular therapy given in selected cases up to 24 hours or beyond also. So all these stroke therapies are time locked, and you should know why they are time locked. Okay, so broad outlook of what happens in the stroke management is given here. If it is an anterior circulation stroke, after the stroke you have to do a once carotid study. If there is dissection, there is a different plan. If there is atherosclerotic stenosis, 100% stenosis, well, nothing can be done. If the stenosis is between 70 to 99% by carotid Doppler or MR angiography or CT angiography, then carotid endarterectomy or stenting is one of the things. If it is less than 50%, what do you do? Known major cardioembolic source requires anticoagulation. Lacunar stroke, no, or it's only antiplatelet agents. Non-lacunar stroke, you have to do various investigations and come to and identify what is the pathology that has caused the stroke. Most important item is cardioembolic stroke. If cardiac testing is negative, consider additional tests according to the pre-test probability, like coagulopathies, etc. So that's a very important broad outlook what we're going to do. But now what we do is we'll go on to the basics, very basics. The big picture of the brain and its functions, which you should know. And those of you who are very new to neurology, and there are very many people like that. So brain has got left and right hemispheres. What does left does is language and praxis, learned motor activities. They're all concentrated in the left cerebral hemisphere. The right has got a spatial representation, and the prosody or the modulation, the stress you give for speech is in the right cerebral hemisphere. So depending on the hemisphere that is involved, you have defects. And it also has anterior and posterior portions. The anterior portion of the brain is action, the premotor cortex and the speech area, they're all action oriented. The posterior aspect is the perception oriented, and you see here the auditory area, here the visual area, here the sort of sensory area. All these areas are very close, so they are perception areas. So sensory is on the posterior aspect, motor in the anterior aspect. And also there is a dorsal and ventral distribution of the functions. From the calcarine cortex, the where pathway, you are finding out in your mind and also where is this problem, that has to go from calcarine cortex to parietal lobe. What is this and how? And if you want to recall that, that goes to the temporal lobe by ventral pathway. So these are the main structures or the concepts which you have to imbibe. And then we look at how the arousal is affected, awareness is affected, because some of you will be doing tests to see what is the whether the individual is able to cognitively impaired or not impaired. Then attention becomes very important, because human beings are evolved from over the centuries, and the frontal lobes are very important for humans, and most of the defects you can find in frontal lobe functions. Memory is very important, language, the vision, spatial attention, motor systems, all these are affected in various combinations in strokes depending on the neuroanatomy. That's why we are having this class today. So the midbrain, the reticuloendothelial system supplies both cerebral hemispheres. So a network of neurons is there that keeps the individual awake. Bottom up ascending reticular activating system keeps human beings, active and aware, conscious. If there is a brainstem stroke, then individuals lose consciousness because the reticular activating system is affected. Whereas in cerebral hemisphere strokes, loss of consciousness is rare, because unless there is a very big stroke involving large areas of the brain, there is no loss of consciousness. Then whatever you are hearing, whatever you are seeing, what you are feeling, they have to be interpreted and come to a conclusion. If that network is disturbed, top down frontoparietal and limbic attention modulation network if is disturbed, then you'll have attention deficits. You see, lateral frontal association cortex is here, lateral parietal association cortex is here, anterior cingulate and medial frontal cortices, precuneus, posterior cingulate, and retrosplenial, upper brainstem, thalamus, hypothalamus, and so. Why I am telling all these areas is this area is called posterior heteromodal association area, where it integrates the auditory, the visual, the somatosensory, and the limbic system inputs. And this disturbance will give rise to a lot of disturbance in the memory, in the orientation, confusional states, and anteriorly it is all motor function. One other important thing is right cerebral hemispheres will give rise to visuospatial defects, and the person remains confused, and he will have no idea that his right is the left hand and left leg, if one for weak he will not be able to identify. That is a neglect part of it. So you can see that what I'm telling you, the brain networks will get disturbed because of the anatomy and physiology, which we have discussed. And these are the main language networks which are surrounding the, see, from the superior temporal gyrus to the inferior frontal gyrus. You can see these are the connections, the arcuate fasciculus that is going. And the why I've showed this network architecture is you can snap any of these wires and give rise to vascular cognitive impairment. The information won't be processed properly. And how many networks are there? There are very important networks which I'm going to show you. This is the perisylvian network, and this is the limbic network, which is important for the retentive memory. You can see the amygdala, and see from here you will start hippocampus, and you can see it goes and then it goes into the posterior part, and then via the fornix, it comes anteriorly into the hypothalamus. So this particular area is very important for memory, that to recent memory. Anything you want to consolidate, recent memory is very important. After 6 months or so of consolidation, the recent memory buffer gets into the remote memory buffer. Then you don't require this to recollect. Otherwise, recent memory, if you want to recollect what happened few days back, last month, or time locked, you require the limbic network. And it gets disturbed in strokes because it's also richly supplied by the blood vessels of posterior circulation. Parieto-frontal spatial network, and which I was telling you from the motor area, it comes down to basal ganglia, red nucleus, and it goes to spinal cord. And the maintenance of the tone, the motor function, the pyramidal tract functions are because of the parieto-frontal network. And the attention and behavior, we have already discussed the top to bottom. And face and object recognition is because of the striate cortex. So on striate cortex and the dorsal Weir pathway and the ventral Watt pathway, and these are the connections. So you can see the axons crisscross across the brain, and any area of damage will give rise to vascular cognitive impairment. So we are bombarded always by sensory stimuli that we filter based on salience, which is important for us. We keep that in mind, and rest of the things we don't. See, and if you have bottom-up ascending reticular activating system damage because of cerebral hemorrhage, you'll have loss of consciousness. If it is in the pons, you get hyperpyrexia and deep coma and bilateral small pupils. If top-down frontoparietal and limbic attention modulation happens like these infarcts in the cerebral hemisphere, you'll have attention problems. So that finishes arousal. Now we'll go on to the frontal syndromes. You can see the frontal lobes, which are very important. Dorsolateral frontal lobe, and totally individual becomes disorganized. You'll have perseveration. He will develop a utilization behavior, stimulus bound behavior. If he sees a blanket, he'll start covering himself with the blanket. And impaired digit span. So these are the main defects which strokes will have if the frontal lobe is involved and the dorsal lateral portion. And against that, you have akinetic mute state if it is a mesial frontal region. Here, the minimal spontaneous action speech. This area is very important for your social interactions, your skills, whatever you have developed in your growth, your interaction with others, your delivery of talks and everything. Everything is controlled by this area. And if this is damaged, then you have minimal spontaneous action or speech. Then the orbitofrontal area, and if there is an affliction of this particular area, the individual will become disinhibited, he becomes impulsive, he becomes emotionally labile, and he'll start having inappropriate jocularity. He may develop hypersexuality. So as you can see, there is a lot of damage that happens in frontal lobe syndromes. The frontal lobes are most evolved in humans. We will take them up when we again discuss the vascular syndromes. So this is the prelude to understand the vascular syndromes. So we have covered the arousal, the frontal syndromes, and now we'll go on to the memory. The memory, there are various types of classifications, but what I'm going to tell you in 2 slides is a very brief description of the memory. You have the iconic memory that is coming from the auditory input and the visual input, and also sensory memory. All these have buffers of milliseconds, and they went into the short-term memory for minutes. And let's look at that. This is important working memory, immediate memory. Now, what happens here is they got the ability to hold information across an undistracted delay, only few minutes. And the location of this buffer is prefrontal cortex. So the magical number 7 plus or minus 2. is given some limits on our capacity for processing the information. That means you can anytime recollect up to 7 plus 2 or minus 2 numbers, telephone numbers, and again do the telephone call, and then quickly forget about it. We are not going to register it. This is very important short-term memory, and this gets disturbed in delirium cases, attention disturbances in ICU. And once short-term memory is disturbed, you will not be able to consolidate and go on to the next step. That is here it is called long-term memory, but it's called recent memory. This short-term memory is minutes, and by rehearsal, it goes time locked into the long-term memory. This memory is not lost by distraction, whereas this memory can be lost because here you will remain focused. And hippocampus and Pepper circuit are very important for this recent memory. The remote memory happens after 6 months. Consolidation takes place where there may be memory of events many months ago. Semantic knowledge, that means the facts of life, all the facts which you gather right from your childhood to your adulthood, whatever you are remembering about anything, that is all semantic memory that is stored in the frontal basal regions, whereas the episodic memory is a part of the hippocampal formation. So this is disturbed in cortex. It's not dependent on hippocampus for retrieval. That much after 6 months, you don't require. So you must have seen people remember a lot of things from their childhood, from their youth, but they don't remember what happened yesterday or a few weeks back. Then the relations thing, his memory is good for old times, but not good for what happens. No, what's wrong with him? Right. So this is a Puppet circuit to understand currently entorhinal cortex, the phonics. It goes to the mammillary bodies here, mammillothalamic tract, anterior nucleus of thalamus. From there go to cingulate gyrus. So this entorhinal cortex is in the hippocampus. This is a Puppet circuit which is very, very important, and it gets disturbed in Alzheimer's disease, where the key issue in Alzheimer's disease is the anterograde learning defect because they are not able to consolidate their memory. There is no learning that is taking place in Alzheimer's disease. In contrast, the frontotemporal dementias, they will have semantic memory defects. So, and another memory that is called a procedural memory. Procedural memory is located in basal ganglia and cerebellum. It doesn't require any of the circuits. And once you are trained, you can keep on performing the procedural memory. So that finishes our knowledge about our brief description of the memory to understand the stroke syndromes. Now we'll go to language, which is very important, and most important is the Heschel's gyrus, which is the primary auditory cortex where you are getting all the auditory inputs. Then the Wernicke's area, which is in the superior temporal gyrus, which is important for comprehension. And if comprehension is disturbed, then you'll have no language disturbance called Wernicke's aphasia, and this area connected to the inferior frontal gyrus left side, and for the language production, that's Broca's area through arcuate fasciculus. There's one particular area, angular gyrus, which links written word with language. Written word can be seen with the visual cortex, and with the language it connects. So any damage in this area, left cerebral hemisphere, angular gyrus damage, will give rise to profound disturbances in the orientation, in the memory, in the understanding. The left cerebral hemisphere is the key of all these. We can see that this is the fluency, comprehension, repetition. These are the important things. The most important of for language assessment, and most of you may be knowing, but the most important to remember is the test of repetition. Transcortical motor and transcortical sensory, the repetition is preserved. Whereas transcortical motor, the fluency is down, the comprehension is preserved. And transcortical sensory, the fluency is okay, but they are meaningless words, but comprehension is nil. So most important test to do is various grades of repetition. And the location for Broca's is, as you all know, inferior frontal, fluency is reduced, comprehension is preserved, repetition is also impaired. Whereas posterior superior temporal gyrus is the area for Wernicke's, and the both transcortical areas may get involved at that time also. So important test is repetition, which is affected by itself in conduction aphasia. So naming is a problem. You ask, show them, you ask them to name an object, they will not be able to name. But by themselves, they can name. If you ask them, they can't name. There, the fluency is preserved, comprehension is preserved, and naming is affected. Some of these aphasias are seen in dementias, and most often we come across strokes. That's a different type of aphasia, because that starts with a global aphasia, because large dominant hemisphere, left side is involved. Fluency is affected, comprehension is affected, repetition is affected, but slowly, the clear picture emerges. That finishes the language. Then, in strokes, the visual problems can happen. There may be defects in the visual fields because of the fibers that go on happening from the optic nerve, the optic chiasma, the optic tract, the optic radiations, and occipital cortex. See, these fibers are also supplied by the blood on the end arteries. And the optic radiations are on twice. This is a Mayer's loop. And if it gets involved, you get visual field defects. So that visual field defects are to be studied, and we are not going to go into the depths of these visual field defects in this class. We may take up some time later, but important note is that the visual defects can give a clue to your localization. If it is a temporal lobe on the left side, you can see the left side, there is a lesion on the left side temporal lobe, and if it's contralateral, superior quadrant nopia. And if it is an occipital stroke, the macular sparing field defect. And if it is a meningioma supracellular, you get bitemporal hemianopia. If it is a right side inferior occipital infarction, you get a left superior quadrantanopia. So by confrontation method, you can see whether visual fields are intact or not intact. Another important aspect of the stroke syndromes. Another important aspect is alexia without agraphia. You can have a 47-year-old man with difficulty in reading and loss of vision to the right side. And that happens because you can see he has got difficulty in reading with loss of vision to the left side. Agraphia, he can write because writing comes from within. Alexia, you have to look at and read. What happens in alexia is the disturbances in conduction from the right occipital cortex to the language areas. There is a defect. So you can see the disconnection of the intact vision of the right hemisphere from the language areas in the left hemisphere. That's why you can't read alexia, but writing is coming from within. So there is no defect in the motor area. So there is no agraphia. That is another important aspect of the assessment. Then sometimes you have to recognize the faces, and that is failure to look at a face and name it is called failure to do that is called prosopagnosia. And this happens because the facial area, the fusiform gyrus and the facial area gets involved, which is in the Watt pathway from Colcrine cortex to the temporal lobe. The fusiform gyrus is involved, then you will not be able to recognize. Show him Mahatma Gandhi's photo, he will not be able to do that. So strokes can affect focal areas, giving rise to various types of defects. And this is the two cortical visual systems which I've been telling you, the Ware pathway and the Watt pathway. That is the vision part which we covered. Now, attention. Why there is a confusion in the right cerebral hemisphere strokes. And if you have to give physiotherapy to them in the right cerebral hemisphere strokes, or you have to plan rehabilitative strategies, very important to understand this. You have the visual fields in front of you. This is the right visual field. This is the left visual field. The left cerebral hemisphere and the right cerebral hemisphere controls the attention in these visual fields. What right hemisphere does is it is specialized for bilateral shifts in attention. If you want to see something here, also go back to here and go back to here. These shifts are controlled by the right cerebral hemisphere, whereas the left cerebral hemisphere controls visual shifts only in the right visual field. So in front of the eyes, you got visual fields. The visual attention shifts that happens from the right visual field to the left and left to the right is controlled by the right cerebral hemisphere, whereas left controls only one side. What happens then? Where are we learning this? So you can see if the left cerebral hemisphere is the only functional thing, it gives only attention shifts facility to the only right side visual field. The left side is totally blank because there is a tumor sitting in the or a stroke sitting in the right side. So this individual is not able to shift his attention from this visual field to this visual field, so he remains confused. The right cerebral hemisphere strokes or they remain confused for a long time. So you can see the right parietal hemorrhage. Right parietal hemorrhage, if you ask them to draw this diagram, he just neglects. You want to cross these lines with a perpendicular line, and he's totally leaving them. You can see the clock drawing and which side. The right side is totally not done at the left side. And you can see the incomplete diagram, incomplete flower drawing. So this happens in the right parietal lesions. So, okay. So anosognosia means lack of knowledge about disease. This happens in the right MCA strokes. If a right MCA stroke chap is asked what happened to you, he will say, I don't have anything. Nothing is wrong with me. Whereas you know that left upper and lower limbs are not moving at all. He cannot move, but he says, I don't have anything. I am all right. So lack of caring about disease also is another aspect. So let us look at a very interesting test that has emerged after anosognosia, that is called Eastchester clapping sign. What happens when a patient with neglect tries to clap? This happened in New York in one of the schools. 11th class student asked the teacher when they were being taught about neglect, Madam, what happens to the stroke patient? How will he clap if he has got an infarct on the right cerebral hemisphere? And nobody thought about it. This Eastchester High School teachers didn't know, so they immediately rang up Massachusetts and asked them, what do people do then? They also don't know. They also never. It happened in 2012 or 2009 to 12. Till that time, nobody thought how are they going to clap. Then they went into their chronic stroke center and identified the right cerebral hemisphere stroke chaps who got a left hemiplegia and asked them to clap. They started clapping with only one hand. Then it is called Eastchester clapping sign, a novel test of a parental neglect. So it's interesting, isn't it? Some of these are very important. Simultanagnosia, inability to perceive global elements. They can't see the forest for the trees. And optic ataxia, poor reaching under visual guidance. You ask him to look at a thumb which you are moving, and he'll not be able to reach a target. You ask him to touch your finger with his finger, he'll not be able to reach that. And you ask him to look at your thumb which you are rotating in front of him, he will not be able to search for the thumb. So this is called optic ocular apraxia, optic ataxia, simultanagnosia. I will describe you what is simultanagnosia, and you can see it's very interesting phenomenon. Very interesting. You can see in a stroke. A 60-year-old woman with progressive impairment of vision and reaching, could be because of stroke also. This is called cookie thief picture, and it's a Boston Diagnostic Aphasia examination. He has to describe the whole thing, what's happening in this figure. There's a cookie jar. This chap is trying to steal. The girl is helping. The stool is about to fall. She's washing dishes and the water is flowing. So you have to describe the whole scene here. But what happens is they won't send. When you ask them if there is a lesion with the Bellnet syndrome, only one thing is that they miss the whole picture, right? So that is the Bellnet syndrome, which you have seen. Now comes the praxis part, the coordinated motor programs. You want them to show how you button up, how you use scissors, how you use your brush. Here, there is no motor deficit, there is no sensory deficit, everything is normal. Still they are not able to perform the learned motor functions. This is called apraxia. The function is called praxis, and when you lose it, it is called apraxia. And apraxia or praxis is in the left parietal lobe. Left parietal lobe, the connections from left parietal lobe will go to supplementary motor area ipsilaterally and onto the right side contralaterally. If there is a disruption in this circuit, see, you can see the supplementary motor area here on this side, then the hell breaks loose. So you will have apraxia, ideational apraxia, ideomotor apraxia, and things like that. Lastly, we are coming to the middle cerebral artery territory. This is the middle cerebral artery territory. If there's an infarct, what you get is a face and arm weakness much more than the leg weakness. If it is anterior cerebral artery territory, which is like this, it is leg more than the arm. If there is a border zone infarct, this is proximal arm weakness in both sides. It's called man in barrel because both the hands are not moving. The legs are okay. The leg is spared and the hand is okay. But the proximal and middle parts of arms are not able to function. That is that. So the post-central gyrus, similarly, it subserves the sensory function. And here the sensory disturbances which we encounter are called cortical sensory losses. The cortical sensory losses, you tend to test with calipers 2-point discrimination. And you also test with graphesthesia by asking them to identify the letters which you are writing when their eyes are closed, and also put something in his hand and ask him to identify the object. And that is a gnosis function. If not able to do that, a stereognosis, a graphesthesia, 2-point discrimination impairment, these are all three called cortical senses. What is the prerequisite for cortical sensation? The prerequisite is intact sensory function, intact motor function. What's happening here is they are not able to process the sensory information to come to a conclusion because of the disturbance of the network architecture, which I have shown you earlier. So then the facial nerve involvement is also interesting to see. The central seventh nerve and peripheral seventh nerve is to be distributed. This is a very common thing. And in central, that means pyramidal tract or cortical strokes, what happens is there's a lower facial weakness. As you can see here, the frontalis muscle is not affected. Whereas here, peripheral, the frontalis muscle is also affected. The whole one half of the face is affected. Not only that, there's some more complication. If you have a facial weakness, which is because of this cortical lesion, there are two types of fibers that are coming. One set of fibers, they are coming from limbic areas of amygdala, globus pallidus and putamen, these are basal ganglia. They are coming down to the facial nucleus. The other is motor areas. From there, these supraspinal fibers, they come down and also control the facial nucleus. Suppose if you have a problem only in this area, that is called mimic facial palsy. Otherwise, these people, if they are intact, if this area is involved, if you ask them to smile, they'll smile, but still their face is and deviated to the one side. So in all the neuroanatomy of the brain, you have seen the big picture. You're known by arousal and awareness, the frontal syndromes, the memory, the language, the vision, the spatial attention, motor system, sensory, and keep this information in your mind. Now we are going to look at the stroke syndromes. So these syndromes, as I recall, this is a middle cerebral artery. We have seen the anterior cerebral artery earlier. Here, the middle cerebral artery has got a superior division and then inferior division. The superior division supplies lateral orbitofrontal branches. This is called a pre-Rolandic branch. This is a Rolandic branch. and the postvolandic branch, and the posterior parietal branch. This is angular artery, and you also have posterior temporal branches and anterior temporal branches. These are coming from the inferior and temporopolar. See, if the inferior branch is occluded, what you get is mostly speech disturbance called Wernicke's aphasia. Here, as you can see, the motor area is not affected. So, Wernicke's aphasia individuals, they suddenly develop incomprehensive and verbal legoria, verbal diarrhea type of speech, and they get admitted because there's no weakness in psychiatry wards. And then once you go and see why this individual developed this, then you realize that he has a stroke here. And the anterior middle cerebral branch or superior branch of the middle cerebral artery supplies the motor area and sensory area where you get hemiparesis, cortical strokes, which I described. And that's because of the middle cerebral artery. We have seen the anterior cerebral artery, which has got the callosal-marginal, pericallosal arteries, and all those branches which we have seen in the anterior cerebral artery. This is a middle cerebral artery. So now let us look at the clinical syndromes. There are large vessel occlusions, there are lacunar strokes. Anterior circulation syndromes, that is middle cerebral artery syndrome, anterior cerebral artery syndrome, including recurrent artery of Hubner, anterior choroidal artery syndrome, internal carotid artery syndrome. These are large vessels that get occluded and cause devastating defects. Similarly, in the territory of posterior circulation, you have artery of Percheron, PCA territory infarcts, including artery of Percheron infarct, anterior inferior cerebellar artery, posterior inferior cerebellar artery, superior cerebellar artery territory, basilar artery perforator. So all these branches, if they are occluded, gives rise to various syndromes. So we have seen in middle cerebral artery, there are cortical branches, and some of these proximal branches supply the basal ganglia, that is lenticulostriate branches. And the distal branches, they are superior and inferior division. So you have seen the superior division, inferior division. So before the MCA branches on superior and inferior, it supplies the ventriculostriate branches to the basal ganglia. So occlusion due to embolus, artery to artery, as I said, cardiac because of atrial fibrillation or valvular heart disease, or there may be intracranial atherosclerosis. So intracranial means there is ICAD. Intracranial atherosclerosis means the sclerotic plaques can obstruct the blood vessels inside the cranial vault. So middle cerebral artery, the M1 segment, if it is occluded, you have a contralateral facial and arm weakness, which is more than the leg weakness. There will be aphasia, contralateral sensory loss, and cortical sensory loss also in the non-dominant hemisphere, contralateral visual field defect, gaze deviation ipsilateral to the lesion. The gaze is deviated to the right cerebral hemisphere, infarction to the right side. If it is the left, it's the left side. So these are the important large vessel clinical syndrome is MCA territory syndrome. This you can see a large MCA infarct in the right cerebral hemisphere here. This is the ADC map and this is the diffusion weighted image, which picks up the stroke within 20 minutes of onset. So complete MCA syndrome at origin, hemiplegia, hemianesthesia, conjugate eye deviation, homonymous hemianopia, global aphasia, and anosognosia, dressing apraxia, constructional apraxia, impaired ability to judge distance and heminucleate on the right side. So because of the involvement of the somatic area, you have hemiplegia. Somatic sensory area, hemianesthesia. Frontal eye field, conjugate eye deviation. Optic radiations, homonymous hemianopia. Dominant hemisphere, global aphasia. Non-dominant hemisphere, anosognosia, dressing apraxia, constructional apraxia, impaired ability to judge distance, and hemineglect. So this is the anterior division. If you want to study separately, what are the features? Mainly two: contralateral facial arm weakness more than the leg, and Broca's aphasia, dominant hemisphere. That is the right hemiparesis, the left cerebral hemisphere stroke. The posterior division, contralateral sensory loss, Wernicke's aphasia, just one syndrome, cortical sensory loss or neglect, contralateral visual field defects. So these are the main defects in the posterior division. So as you can see in the posterior division, there is no motor weakness. Partial MCA syndromes, superior division, you can have brachial syndrome, only facial-brachial weakness, only Broca's aphasia, and facial, that is the only arm weakness. The partial MCA syndromes are also known. And the inferior division, you have mainly, you can have only Wernicke's aphasia if it is the dominant hemisphere, wherein you come across jargon, speech, contralateral, homonymous, superior quadrant myopia, which I showed you the field defects in the dominant hemisphere. The non-dominant right cerebral hemisphere, there may be hemi-neglect, spatial agnosia without weakness. The Gerstmann syndrome, dominant angular gyrus can give rise to finger agnosia, acalculia, agraphia, right-left disorientation. That particular angular gyrus area, which is the center for posterior heteromodal association area I have shown you. And now we go to the anterocerebral artery branches. There are cortical branches, post-communal segment. There's a stem and the penetrating branches to anterior limb of internal capsule, anterior perforate substance, amygdala, anterior hypothalamus, inferior head of the caudate, anterior part of the globus pallidus. So the recurrent artery of Hubner, which will give rise to infarct in the caudate nucleus. So infarction is less common, less than 3%. And usually these syndromes are seen in subarachnoid hemorrhage from anterocerebral artery and anterior communicating artery aneurysms. And there may be occlusion of the proximal branch, then it is well tolerated. Anterocerebral artery syndrome causes contralateral leg weakness more than the hand weakness, contralateral leg sensory loss, and if it's apraxia, abulia, if it's on the left side, apraxia is more common. And contralateral hemiparesis involves foot and leg because of the leg area of the cortex. Sensory area for foot and leg are involved. And urinary incontinence also is seen because paracentral lobule is the control center for micturition. And contralateral frontal release signs are also seen, Gegenhalten, because of supplementary motor area involvement. As I said, akinetic mutism, bilateral mesiofrontal damage, memory and emotional disturbances, transcortical motor aphasias, and that's because of dominant lobe involvement on the left side, and maybe anterior disconnection syndromes with left arm apraxia if anterior corpus callosum is involved in the infarct. These are some of the ACS syndromes. And one of the important thing is recurrent artery of Hubner, weakness more pronounced in the face and arm without sensory loss due to involvement of the anterior limb of the internal capsule. You can see the Hubner's infarct in the territory of the recurrent artery of Hubner, which is in the caudate nucleus. And there is one more artery which is called anterior choroidal artery, which is also a branch of internal cerebral artery. It supplies the posterior limb of the internal capsule. So as we are going towards the internal capsule, you are getting branches. What are these supplies of internal capsule? Internal capsule is very important because all the fibers in the cerebral hemisphere, they go down through the internal capsule into the brainstem, into the medulla, pyramids, and spinal cord. So there is a congregation of the fibers in the internal capsule. Blood supply of internal capsule is very important because any compromise there will cause devastating flaccid hemiparesis, which will not improve to a large extent. The anterior choroidal artery, usually in surgery, it gets affected where it causes contralateral hemiparesis because there is involvement of posterior limb of internal capsule. There will be hemianesthesia because of the posterolateral nuclear thalamus, which is the crude center for the sensations. There will be homonymous hemianopia because there will be a sparing of horizontal meridian on the visual field effects. This damage usually recurs substantially because there's no language dysfunction, normal cognition, no language dysfunction. So recovery is better. It's also a large vessel occlusion, and the lateral geniculate body is involved. That causes the homonymous hemianopia, and the face, leg, and arm weakness is because of the posterior limb of internal capsule, and the sensory loss is because of thalamus, as I said earlier. And these are the some of the areas of damage of the anterior choroidal artery involvement. You can see here. These are the types of the strokes which you see in the anterior choroidal artery. involvement. The recovery is very good in these areas. And the main artery, internal carotid artery, artery to artery embolism can get affected. There will be fixed obstruction. There is varied presentation depending on low flow, thrombosis, and embolism, propagation into middle cerebral artery, massive infarction, amaurosis fugax in about 25% of the cases. And it causes ipsilateral retinal ischemia, that is amaurosis. The transient, as if a curtain has come in front of the eye, that is the TIA part of it, that is amaurosis fugax, and there is sensory motor dysfunction similar to the involvement of MCA and ACA territories. Because both these branches are coming from internal carotid artery, the area of damage is much wider. And if there is a pain, there is a ptosis and some meiosis, and you should always think of ICA dissection. The pain in the stroke is very rare. If pain is there, you have to think there may be ischemic stroke, there may be dissection, which the pain happens ipsilateral to the area dissection. Dissection means there are three layers of the blood vessel: intima, media, and though if there is a disruption in the intima, the blood percolates in between the intima and the media, and the outer layer is the adventitia. So whenever the blood percolates and enters the vessel wall, it causes obstruction. That is called dissection. And TIAs and stroke minutes to weeks after the onset of the pain can happen. Sometimes you can have pulsatile tinnitus, and dysgeusia also can happen, the smell disturbances. And so you have to identify this type of dissections also are frequent occurrences. Now we go to the posterior cerebral artery pre-communication part, what it causes. There is a sensory loss, thalamus is involved, and cognitive dysfunction also because thalamus is involved, and because there also is a center for speech, so thalamic aphasia. And there is a visual dysfunction because there is a posterior communicating segment is involved in the thrombosis part, and lateral geniculate body is involved. So there will be posterior cerebral artery syndromes. You can have a infarct like this. You can see the thalamus is involved. Something called artery of Percheron, that is the single thalamoperforator artery, which is coming from P1 segment of the posterior cerebral artery. Usually there are two like this, but here the two is coming only from one. So if that happens, you have the artery of Percheron infarction, both sides of the thalamus, which is seen like this. And then the pica territory infarct, which has got Horner syndrome, hemiataxia, and palatal weakness and hoarse voice. But there's no weakness here. Decreased pain and temperature on the ipsilateral portion of the face and contralateral limbs. So this is the pica syndrome, which is characteristic. And the AICA syndrome has got deafness, facial weakness, hemiataxia, hoarse voice, contralateral sensory loss, and limbs. The superior cerebral artery, you got cerebral artery has got ipsilateral ataxia. There is a sensation problem also contralaterally and diplopia. So the basilar perforators, they give rise to limb weakness and quadriparesis because pons has got all the fibers. At times there may be ataxia hemiparesis, hemiataxia, and cranial nerves get affected, 7th and 6th. And there may be internuclear ophthalmoplegia, which is the defects that are seen in the eye examination. So midbrain also has got ipsilateral nucleus of vesicular third nerve palsy, that is called Weber syndrome. One side you have Weber syndrome, that is third nerve palsy, contralateral hemiparesis, that is called crossed hemiplegia, contralateral facial arm leg weakness. And if red nucleus is involved, there is a rubral tremor, proximal tremor of the limb, and also ataxia because there is decussation of superior cerebellar peduncle. And because spinal cord is involved in anterior spinal vertebral artery perforators to median paramedian areas, you have tongue weakness, contralateral arm and leg weakness, and contralateral arm leg weakness, and the medullary pyramids are involved. So sensation are disturbed, proprioception especially, and weakness. This happens if you have anterior spinal and vertebral artery perforators. So I think these are the large vessel clinical syndromes. And the small part about the lacunar, which are small ischemic infarctions in the deep gray matter of the brain, and 0.5 to 15 millimeters in diameters. They result from occlusion of the penetrating arteries, which I showed you. And these five are characteristically seen, that is pure motor hemiparesis, pure sensory stroke, sensory motor stroke, dysarthria, clumsy hand syndrome, and ataxic hemiparesis. And these are the important things which we keep coming across in our day-to-day practice. And ataxic hemiparesis means usually ataxia doesn't happen on the side of hemiparesis, but if it happens, the lesion could be in basis pontis and posterior limb of internal capsule, and the deep areas of the basis pontis will cause dysarthria, clumsy hand syndrome. This is the last slide which I'm going to show you. The middle cerebral artery territory of the internal capsule is here. The anterior cerebral artery territory is here, and the anterior choroidal artery territory is here. So we have a quick review of the cerebrovascular anatomy and the various clinical syndromes. It's tough to grasp so much, but we tried covering up as much as possible with some physiological aspects, some anatomical aspects, some the big picture of the brain and what are the major deficits. And if there are any questions, you can ask. You can unmute yourself and ask.
A very informative lecture. Actually, it was very helpful understanding stroke and correlate the patient at bedside we see or chairside we see. I wanted to ask you, sir,
Mhm.
when we have patients with mostly temporoparietal or occipital strokes, so how do we say the cortical blindness? Are they unilateral cortical blindness also? Do we see them clinically, or do you have a better collaterals when it comes to the posterior strokes? And no, not every time we get to see patients really doing well with the perimetry, because sometimes they don't understand if they have some aphasic agnostic disturbances along with their perceptual difficulties.
The important aspect to know is that cortical blindness happens if bilaterally calcarine cortex and area 17 and 18 are involved. And the representation of macula is very large when compared to the other areas. So to have blindness is very difficult. Cortical blindness can have, it can be present if bilateral damage is there, because there is a rich blood supply to the occipital cortex. Bilaterally the vessels supply. So it's very difficult to have cortical blindness unless the Anton syndrome, which they are not aware of, the blindness also happens if large areas of calcarine cortex is involved. And as you say that the part which is close to the posterior heteromodal association area, these people, individuals usually remain confused and they don't know. There are many of these deficits, the agnosias and the apraxias, and all these things will come because it's a perception area. The posterior part of the brain is perception area because it integrates the visual input, auditory input, somatosensory input, and limbic input to formate concepts and ideas and to recollect them. This area is very important.
Thank you so much, sir.
Hmm. Okay, I think most of them got bored, so they all left, I think.
No,
But
no,
anyway.
no. I think we had all the students and faculties also like attending till 9. We had more than 15 people, sir.
Yeah, I know that. But it's a long lecture. Next time we'll keep it short.
Very informative. So very thankful to you for this.
Okay, then shall I say then end show and good night to everybody. Okay, then thank you
This
very much.
lecture will be available on Neuro e-Pathshala. All of you visit and you can have even earlier lectures visited. So it's very scholarly, very helpful, and we are blessed to have him in our hospital as our teacher in neurology. Thank you so much all. Good night.
And I request all of you to become to subscribe to the channel
Yes,
so
sir.
that you can see them. Okay, thank you very much.
Thank you, sir. Good
Yeah,
night.
good night.